In this module, we will study medical nutrition therapy for diseases of the respiratory system. So we know very well that nutritional status and pulmonary function are interdependent. We know that to fully metabolize macronutrients, we need an adequate amount of oxygen. And of course, it is our lungs that bring the oxygen. Also, one of the end products of the metabolism of macronutrients is carbon dioxide. So this will be exhaled out of the body through the lungs as well. If someone has pulmonary disorders, we can imagine that the body would have a compromised capacity for macronutrient metabolism, and it would be at high risk to develop, malnutrition. So when this happens, it can actually contribute to the further decline of the pulmonary function. Therefore, malnutrition and declining pulmonary status kind of feed into each other. They form this vicious cycle. So here's an overview of our respiratory system. So we know that our respiratory system is found above the diaphragm. So it's located in the thoracic region here, and also up in our head and neck cavity. So of course we know for our nose, we use it to bring air in, and that goes down our larynx and trachea all the way down to our lungs. And if we look at the structure of the lungs, we can kind of think of it as an upside down tree. So we can consider this area here like the root part, and then this part of the tree here, which is the trachea, that's going to be the trunk of the tree. And then our trachea branch into the bronchi, into the right and left lung, and then it goes down into these tiny, tiny little airways all throughout the lung. So again, thinking about this as an upside down tree, the leaves are going to be these very tips that have branched off here, and that's what we call the alveoli. So these are the small air sacs at the end of each tiny airway. And the capillaries in the lung tissue interact with the alveoli. Basically, they will have air coming from the outside, and the capillary will have the blood in it. And then there will be exchange between the gases here, between the air and the blood. So our blood would take in more oxygen and then at the same time release the carbon dioxide. And this is how our lungs fuel the system for the whole body, supplying it with oxygen and taking away the carbon dioxide waste. So the lining of these small air sacs have two different types of epithelial cells. So type 1 is serving a structural role. It forms the wall of the air sac. And then we have type 2, and this is responsible for producing a chemical called surfactant. So this is the chemical that helps the alveoli stay inflated because, for the small air sacs to function, they have to remain inflated to allow the maximum amount of air to come in and go out of them. And we will talk about certain conditions where the alveoli actually collapse. In that case, the patient will lose a lot of lung capacity because there's what we call dead volumes inside the collapsed alveoli. So the type 2 cells are actually not fully mature until the end of pregnancy. Therefore, it can be very challenging for newborns who are born prematurely to have normal respiratory function. So this is why a lot of premature babies receive respiratory support. It's because this allows them time for their lungs to be able to produce an adequate amount of surfactant so that their lungs can function properly. So as we mentioned, we can see here how the capillaries interact with the lung tissue. We have the alveoli wall here, and then we have the gases going in and out, so exchanging over this membrane into the blood. So we have the oxygen going in and the carbon dioxide going out of the capillary. By the way, both oxygen and carbon dioxide can be carried out by the hemoglobin in the blood. So we already are well aware that hemoglobin carries oxygen, but when the red blood cells come back from the peripheral tissue after unloading the oxygen to those tissues, the hemoglobin can also, to a certain extent, pick up some CO2 from the peripheral tissue and release it into the lungs. So in addition to this essential gas exchange function, our lungs also have other roles. For example, long airways in our system can help us filter and warm as well as humidify the air. So from when the air first enters our body in the nose until it reaches the alveoli, that's a pretty long distance. Remember all the branching we saw there. So during this process, as the air travels down, it can be filtered if there's anything, say for example, dirt or pollen in the air, then we have structures in the airway to contain them. Also, we can add humidity to the air, and if it's, we're out in a cold climate, when the air travels inside our airway, it gets warmed up so it doesn't hurt the tissue deep down in our lungs. And because our lungs expire CO2, and we know that carbon dioxide, when dissolved in a water, is a weak acid called carbonic acid, our lungs actually play a function in regulating our acid-base balance. Thus, we have conditions such as respiratory acidosis and respiratory alkalosis. So these are referring to conditions where, due to compromised lung function, a person is either getting acidosis or alkalosis. Our lungs can also synthesize arachidonic acid, or AA. So this is one of the omega-6 fatty acids that has that 20 carbons in total, with the first double bond being on the 6th carbon. And arachidonic acid serves as a precursor for many bioactive compounds in our system, and many of these serve as inflammation mediators. For example, prostaglandins, leukotrienes, thromboxane, all of these can come from omega-3 as a precursor. Our lungs also participate in regulating fluid balance and partially in regulating blood pressure. As you've discussed when you learned about hypertension, I'm sure they mentioned the renin-angiotensin system. And in this system, the lungs contribute to an enzyme called angiotensin converting enzyme, which is key in activating angiotensin 2, and that's the potent hormone that enables the body to retain more fluid and sodium. So therefore, this enzyme is a target for patients with hypertension as well as other conditions where we need to reduce the fluid retention and sodium retention. So if you remember the types of medications used for hypertension, there was one called an ACE inhibitor. So that's the angiotensin converting enzyme inhibitors. And we remember that the commercial names of these medications always end with pril, P-R-I-L. For example, lisinopril. So pril is, that ending is indicating that it is an ACE inhibitor. Our lungs also have an immune function because if we think about it, our respiratory system is among the few systems in our body that allows compounds or materials from outside the body to enter directly into our system, right? So if we think about that, that's really just our respiratory system and our GI system. Therefore, it's very essential for our lungs to be able to fend off certain invaders. Otherwise, our immune system would be constantly challenged and not able to protect the rest of the body as well. So there are structures in the airway that help with this function. For example, we all have hairs in our nose, and these hairs allow us to fend off a lot of bad things filtering the air that we breathe. And then once we go further down the airway, actually along the wall of the airway, there is mucus, and this can trap substances such as dirt and pollen and things like that. Also in the airway, we have hair-like structures called cilia. These tiny hair-like structures can propel mucus and unwanted cells upwards to the point where we're able to cough them up and let them out. Also, there are immune cells in the alveoli that can literally engulf and destroy bacteria. So now, how do we measure pulmonary function? Well, first, because it's the lungs' job to breathe in oxygen and breathe out carbon dioxide, it's very important for us to hear how well the lungs are functioning. So we can use percussion and oscillation to listen. So we're listening for how long the lung reacts when it breathes in and breathes out, or when we're tapping onto the chest cavity to see whether it's hollow sound or if it sounds more solid. And so by doing this, it can help doctors diagnose pulmonary consolidation, for example, if there is severe pneumonia. So certain parts of the lungs may have a lot of inflammation going on with a lot of fluid retention. And so that part of the lungs is no longer filled by air, but by solid tissue or even fluid. And then this would give us a different sound. Then, depending on how open the airway is when we breathe, the air traveling through the airway could give a different sound through a stethoscope that we might be able to catch. So well-trained physicians can have a pretty good idea of what's going on by listening to different sounds. If we want to further test exactly what's going on with the lung function, we could do a pulse oximeter. So knowing that oxygen comes from our lungs, if we check the oxygen saturation in our hemoglobin, we would be able to get a very good indication of the lung function. So this is somebody with a finger pulse ox or pulse oximeter on there, and it's just like a little finger prick testing the blood to see what the oxygen saturation of the hemoglobin is. We can also use a spirometer. So in this, basically the individual blows all the air they can into a meter and we measure the volume. So we see here FVC, and that stands for forced vital capacity. And in this test, we just take a deep breath and breathe out as forcefully as possible for as long as possible. This indicates the maximum amount of usable capacity in our lungs. Also, when we'll talk about COPD later on, we'll mention this measurement as well. So this measures forced expiratory volume in 1 second. So there's still that forced exhaling, but we only record the volume in 1 second. And this is a very useful indicator when diagnosing COPD. We can also check lab values and take blood samples. So we have ABG, that stands for arterial blood gas, because we want to know about the oxygenation status of the blood. So in this case, it makes sense to be taking arterial blood. We want to be using that rather than blood from the veins. We mentioned oxygen saturation and pH in the blood because of the carbon dioxide that depends on the lungs to be disposed. So therefore, the pH value or the balance in the blood could also reflect our lung function. So here we have the normal values of a lot of markers when we analyze the arterial blood. So just a reminder, our normal blood range of blood pH, it's very narrow. It's between 7.35 to 7.45. And also one thing I want to mention here is minute ventilation. And this is given in liters per minute. And this is very important for patients on mechanical ventilation. So we'll be looking for this number in the chart, and we use it in the Penn State calculations when we're estimating energy requirements for these patients. We already mentioned that pulmonary health and malnutrition status are interconnected. And if someone's malnourished, we know that that's associated with poor intake. So this could reduce the strength and endurance of the muscles of our lungs, so the muscles that our body uses for breathing. And obviously muscle wasting could have an effect on this. Of course, when that does happen, we will have less strength, and when we're taking in air or getting out of air, it might be much more difficult to do. So, as people with malnutrition lose lean muscle mass, this includes their respiratory muscle, and they may be too weak and lose the ability to cough up unwanted things, and their body's just, too weak to do some of the normal functions that it would do. So also remember, in the lungs there are immune cells as well, so long-term malnutrition could decrease the ability for the lungs to fend off unwanted invasions. Therefore, continued malnutrition increases risk of infection. And we have mounting evidence that connect the role of dietary antioxidants with healthy lung functions. So antioxidants, again, we're thinking vitamin C, vitamin E, a lot of minerals, selenium, and omega-3 fatty acids also have an anti-inflammatory effect. And we know cigarette smoking is associated with reduced levels of antioxidants. So we already know that cigarette smoking in itself harms lung tissue, but there's an additional mechanism. Antioxidants are good for lung function, but cigarette smoking can reduce the action of the antioxidants. And when we have a patient suffering from respiratory diseases, it is very common for us to see that their dietary intake declines. So the root reason that the body with this condition will not have an adequate amount of oxygen supply, so this is going to affect metabolism at the cellular level and compromise that. So That's one thing, but also because the body is not giving enough oxygen and the muscles are likely weakened or being wasted, many patients will experience early satiety or loss of appetite. As a result of this, they will have unintentional weight loss. And because they are fighting for air due to respiratory disease, we'll see the cough and dyspnea, which is difficulty breathing, and all of this can affect their eating and their dietary intake. So just imagine if someone's having breathing difficulties, they're probably not going to prioritize oral intake, and so this is something that we want to keep in mind as we discuss nutrition in relation to respiratory disease.